to see if what we have just listened to can really prevent the postthrombotic syndrome. The goals of therapy for DVT, according to good old, my own thoughts, are to prevent extension and recurrence of the DVT, to prevent pulmonary embolism, and to minimize the early and late sequelae of DVT. Most clinicians seem to focus on the first two goals, disregarding prevention of the postthrombotic sequelae. And if we look more specifically at the iliofemoral DVT, what do we want to prevent? Extension of the thrombus with subsequent pulmonary embolism, which will occur in more than 50%. Progressive swelling of the leg, you remember my picture of VENOUS, and increased compartmental pressure, which can lead to phlegmasia cerebelli-dolens, venous gangrene, and limb loss. And the severe postthrombotic syndrome by preservation of venous outflow and valve function. The risk to develop the postthrombotic syndrome despite appropriate anticoagulant therapy, about 50% of patients with DVT will develop postthrombotic sequelae, which can be severe in up to 20% of this population. Although it's not possible to foresee the development and course of the postthrombotic syndrome in the individual patient, clinical predictors of PTS are identifiable at the time of acute DVT. Categorization of patients at risk. Clinical factors at initial presentation and at 30 days can allow a categorization of patients at risk for the severe PTS. Proximal DVT involving the common femoral or iliac veins, elevated BMI, previous ipsilateral DVT, and older age are associated with the development of the postthrombotic syndrome. Predicting factors number 1. Iliofemoral DVT is associated with a higher frequency and more severe PTS than distal DVT. Greater postthrombotic Villalta severity score at the 1 month visit strongly predicted higher means postthrombotic scores throughout 24 months follow-up. Number 2, initial insufficient anticoagulation treatment is associated with an increased risk of thrombus propagation, pulmonary embolism, and recurrent DVT. Anticoagulation alone imperfectly protects against the occurrence of venous obstruction and valvular destruction, resulting in ambulatory venous hypertension and potentially PTS. 3. The effects of elastic compression stockings following DVT have been well documented, with reduction in venous hypertension, decreased edema, and improvement in tissue microcirculation, well shown by Hugo Patch. When stockings are combined with early ambulation, rates of PTS are decreased. Lack of compliance increases the risk. 4. Early thrombus removal using open surgery catheter-directed thrombolysis or pharmacomechanical thrombolysis has been shown to decrease vein wall injury, preserve valve function, and ultimately translate into decreased rates of PTS. Stenting of remaining iliac vein obstruction seems to improve long-term patency. We will hear from Nils Beckord about his excellent results with thrombolysis. He had 103 patients with iliofemoral DVT treated with catheter-directed thrombolysis with a mean follow-up of 34 months with 91% deep venous patency without distal reflux. 5. Chronic obstruction of the iliofemoral segment following acute DVT is common, as only 20 to 30% of the iliac vein thrombi recanalized with anticoagulation alone. Proximal obstruction, independent of distal reflux, is the principal cause of PTS in approximately 30% of the cases. Percutaneous endovenous angioplasty and stenting is the treatment of choice. And here we see the results of Peter Neglin and Raju in a large number of patients followed for 6 years with excellent results. And Olivier Hartung from Marseille can show a similar outcome. 6. Recurrent ipsilateral DVT is the primary and probably the most important etiologic factor in the development of PTS. Reducing the rate of recurrent DVT will thereby decrease the incidence of PTS, and this can only be accomplished by instituting the measures mentioned before. The development of PTS. Early PTS symptoms after DVT correlate with poor long-term outcome. The underlying pathology of this process is unknown. The mechanism driving the progression of PTS and whether its course can be halted or even reversed is unknown. The inflammatory response is involved, but the relationship between inflammation and venous reflux and obstruction is unclear. The American Venous Forum has suggested CAP as the DVT risk prediction score, where S stands for symptom severity, E for etiology, provoked or unprovoked, A anatomy, and that's clear, not only proximal and distal, but iliofemoral versus femoral-popliteal versus calf veins that Kes Wittens talked about yesterday. And P for pathophysiology, whether it's primary or recurrent. So, who is at high risk to develop the severe PTS? Iliofemoral DVT, old age, elevated BMI, recurrent ipsilateral DVT, non-optimal anticoagulation, non-compliance with early ambulation and stockings, no attempt of early thrombus removal, poor recanalization on duplex scanning after 1 month with elevated D-dimer, high